There we go. What I was thinking of doing is seeing what questions people have, first of all. And then I did post in the week 11 and week 12 modules a heart failure study guide and a critical congenital heart defect study guide. So you have those available to you now. I kind of would just like to stick with the heart failure because I'm kind of tired, just to be perfectly honest. And that way we can just, focus on one topic, and then we will for sure pick up next week. And also the grades for the in-class quiz are now finalized. So that quiz will count as your week 13 quiz. If anybody has questions, feel free to make an appointment or message me or whatever to discuss, but that's one extra thing off your plate. Yay. Um,
Thank you for
so
doing
uh,
that. Um, I just had a quick something I noticed. I'm not sure if they're supposed to be counted under quizzes and grades, but I think they're still under assignments technically.
Are they? Okay, because I tried to make it, I counted it now to the grade. I'll try to
Okay.
make sure that I thought I did it, but thank
I
you for letting me
You
know. I
could
will
be
double
right.
check,
Okay, thank you. Appreciate it.
but I'll double check. Um,
Thank you.
I'm pretty sure it counted, but yes, for sure. We want it to count where it needs to count the most. Um, you're welcome. You're welcome. What questions? Let's talk about heart failure, like right, left-sided adult heart failure first. Um, are there, what questions do you have other than what will be on the test? Because I'm not even sure yet, but I know the things I want you to focus on. Um, if you don't have specific questions, I can just run through the study guide with you, or if there's a PowerPoint or something you want me to review, let me know.
I feel like I understand that left-hearted is associated with lungs and the right, you could say, is rest of body. But I feel
Hmm.
like the congenital ones, where they're like surgery is necessary versus not necessary, I still haven't gotten that really down. So that's just where I'm coming from for
Okay.
this session.
Okay. I certainly can start with the congenital defects first and run through that study guide if you would like. Kat says run through the study guide would be great. Um,
Either way is fine. Thank you.
either way is fine. Okay, no worries. Um, People want study guides. Okay. Let me figure out here. Nope. Hold on one second. Let me find what the heck I'm looking for. That was not what I'm looking for. Yeah, I was at the school and I just ran home, so I'm still a tad discombobulated. But I will get it together, huh, Petunia? We'll get it together, huh? Yeah. Okay, heart failure study guide. Again, the study guides are built off of the objectives. So, and I gave you some visuals here. I'll pull it up. You also have it available to you to pull up, write notes on. Um, ba, ba. Okay, now I can share, I think. Nope, not that one. Okay, screen two. That one. That's the one I want. Okay. Share. Okay. Do you see it says lesson outcomes, heart failure study guide? Is that what you see on your
Yes.
screen? Yes, thank you. Okay. So again, what I basically did was go through the objectives and put information or highlight the things that uh, I think are important for you to know that you should uh, oh, good. Information quizzes under quizzes and exams. Oh, good. Thank you for checking. Um, and kind of tried to highlight the ones to know. Okay. So, for example, under the first one, how heart failure occurs using central perfusion. We're talking central perfusion in terms of because it has to do with the heart as opposed to peripheral type things, peripheral cyanosis or things like that. We're talking central perfusion. So the main concept really to, I think, understand or hope that you all understand is the cardiac output equals the heart rate times the stroke volume. And if you think about it, the heart rate, we know that's how fast the heart is pumping. The stroke volume is actually composed of, which I'm not sure we really got into detail in class, but is actually part of the preload and the afterload, as well as the ability of the heart to contract. So, what is the preload again?
The filling of the chambers, yeah.
The filling, yes. Preload, we're filled, the chambers are filling. Yes, good. Filling, yes. And then the afterload is
The ejection of the chambers.
the ejection, correct. Yes. And so it's actually the afterload is actually systolic and the preload is diastolic.
Yeah.
Yeah, because the systolic is pushing and the diastolic is filling. And then contractility just really means the ability of the heart chambers to contract, meaning can they stretch to fill and can they contract to eject the blood to the body. Nice. Okay. And that's basically, if you can understand that, that will take you through third and fourth semester as well. If you have that concept down and can understand preload, afterload, that will be amazing for you. The next objective was noticing risk factors for heart failure, looking at conditions that decrease cardiac output. So the way it was worded, I thought was a little bit confusing. So I kind of tried to say it a little bit differently in terms of things that would change the heart conduction. So basically, like, excuse me, like a heart attack, right? An ischemic event, that's going to affect the contractility of the heart because there's ischemia. It could also affect preload and afterload because it's ischemic. There's no blood flow. There's a dead part of the heart, and so that would affect the myocardium. There can also be a problem with the heart itself, some kind of cardiomyopathy that's come about from like an endocarditis or a pericarditis, any of the inflammation or infection of the layers of the heart, anything like that. Of course, hypertension, that's always a risk factor. And then talking about systemic resistance or problems with the heart valves, because the heart valves have to open to let the blood go through, and they have to close to keep it there and not let it come back, regurgitate back. And so valve regurgitation is a problem because the blood will slip back and not be ejected with as much force or volume as it needs. And then valve stenosis means that the blood has to fight an increased pressure because there's a stenosing, a narrowing of one of the vessels that's trying to get out to the body. And so those are ways that not so much talking about, oh, is smoking a cause? Those other things are causes that get us to this place. And so the hypertension can cause problems, but what's causing the heart failure itself is that the blood either there's some problem with that cardiac output, stroke volume, heart rate piece to it. And so those are just some different examples of that. For objective number 3, I don't have it highlighted. I'm not going to ask you about the RAAS or we're going to talk about BNP, the beta natriuretic peptide. But that's why it's not highlighted, but I gave you the information just in case you want to use this, or keep this however you want to use it, but I'm not asking you, so it's not highlighted. Does that, you understand that makes sense? Yeah. Thumbs up, something. Okay, thank you, Kat. Brenda, yes. Okay, and so now what we're going to look at is types of heart failure, problems that, how do you know, which will lend itself back to that left-sided, right-sided mixed, which is what they're calling biventricular, so meaning both ventricles, because it's really problems with the ventricles when you're having heart failure. So let's kind of look at that a little bit. Make that a little bit bigger. So when we talk about, we kind of didn't get into much talking about compensated versus uncompensated. We're focusing in second semester on we are focusing on chronic. So compensated heart failure would be congestive heart failure, something that's a chronic disease, not something that is just happening, right now, or there was some traumatic event or something that is causing or like a heart attack or something that might put you into heart failure. So we're talking about sort of a long process, like the clients that you see in long-term care. Many of the clients you're probably seeing in med surg have congestive heart failure or what we consider a compensated heart failure. And so one way to kind of look at that, which I thought, oops, here we go, which I thought this was a good kind of picture to look at, is that basically when you have heart failure, there's a decreased cardiac output, right? Either the heart can't fill or because there's too much pressure, too much fluid. And so you're going to somehow then you need to get either the stroke volume or the heart rate up to compensate for that. And so that's basically what the body does is compensate using those mechanisms. You don't, again, I don't need you to know that at this level, the RAAS or the kidney resorption of sodium and that kind of thing. Just know that there are mechanisms that are being used to compensate, and those are the clients that we're thinking about right now. When you get into third and fourth, then you'll be talking more acute, or what happens when these compensatory methods don't keep compensating. Does that make sense? Yeah, thank you, Hunter. Okay, and so then we just said we talked about the filling being the diastolic and the ejection being the systolic. And so that again is somewhat of another definition of heart failure, right? So the ventricles can't contract or they can't fill in order to make the blood flow. So that's just kind of repeating ourselves there. And then we did talk about in detail, so it is highlighted, about left side heart failure, right side heart failure, and I'm just going to say biventricular because we're talking about the ventricles, which would be the mixed heart failure. And so, right, the left-sided heart failure, the left ventricle output decreases, and the left atrial pulmonary venous pressure increases. And so the left ventricle can't eject enough blood. Remember that ventricle's going up to the aorta, and there's so much pressure that it can't push the blood, and so that blood then backs up. Remember, everything kind of backs up, and where is it going to back up to? In this case, in left-sided heart failure.
Is it going to back up back into the lungs or through the pulmonary?
Yes. Yes. Yes, because it can't get out of that left ventricle to go forward to the aorta. It backs its way up into the lungs. And that is why left-sided heart failure has the pulmonary symptoms that you see or hear, I guess, right, when you're listening to lung sounds and such. And so so that would be left-sided. Crackle, shortness of breath. Yes, yes. And then when you have right heat failure. Sorry, it's supposed to be heart failure. Oops. Then the right ventricular output is reduced. And so the right ventricle is supposed to be pumping to the pulmonary, but it can't do that as effectively. So where does that blood then move backwards to? From the right ventricle. Systemically. Yeah. Thanks. Oh, hi, Brad. Yeah. And so the body, yes, extremities, yes, because it's going backwards. And so what happens is why they call it biventricular heart failure. Hi, Tweety. Is ooh, I get a wave under the blankies. Thank you. I wish I was under a nice. No, you're fine. I'm great. Well, maybe it'll put him to sleep for you. We'll put you to sleep, buddy. Because the ventricles, neither one is working well. And so things are backing up to the lungs, they're backing up to the body, and then the body backs up to the lungs, and the lungs back up to everything just backs up. And so you have pulmonary hypertension, which is pulling it back. The right ventricular failure follows the left ventricular. Like, remember I said we usually would have left-sided heart failure first, and then it will go to right-sided heart failure. Don't need you to know about high output heart failure. Clinical manifestations. I don't necessarily need you to know the stages, just that it is staged and gets worse. It can get worse. Let's see. Chronic heart failure, again, as opposed to acute heart failure, which is what we would call congestive heart failure. Everybody still with me? Making sense? Questions? Alex, good. Okay, thank you.
Yeah.
Or that's Hunter. When you start to talk, your box lights up green, and then I got a thumbs up from Hunter. So, do you have a question, Alex?
No, I don't.
Oh, okay, no worries. Um, okay, so now looking at those clinical manifestations, what is that client going to look like? So different types of questions that I might ask would be based on these symptoms. Is this right or left? Or they have left-sided, what do you expect? Or maybe these are the symptoms, what do you expect the doctor to order, the provider to order? Those similar to what you had on the second exam, those types of questions. And so I know ATI says, I believe something a little bit different than this. I tend to go by my lecture notes and my PowerPoints, not as much ATI. So I would say learn what is here on the study guide. I'll try to keep it fairly the same as ATI, but I'm not going to guarantee that. So know what I have here. Unless there's some other mnemonics that you have to remember it, that's fine. But this is what if I pull questions about this, I will pull it from here. And so you have your respiratory and your right-sided, excuse me, respiratory and your systemic, and then you'll get some kind of combination of those if it's biventricular. And then the diagnostic tests specific to heart failure, those are different. I didn't put cardiac cath. I probably should have put cardiac cath there. Oops, sorry. Cardiac catheterization, because we did talk about that in the case study. But chest X-rays we look at, electrocardiograms, echocardiograms, and our babies in the NICU get these. They get maybe not EKGs, but we do a lot of echoes in the NICU to check heart function. CTs, MRIs, the regular labs like your CMP, BMP, electrolytes, CBC, all that kind of stuff. And then also the BNP. So the B type, there's actually an alpha type too, which has to do with the atria. And then the beta type has to do with the ventricles, which is what we're looking at in heart failure. And so it's released by the ventricle when it has to work extra hard to pump the blood. We're going to use the less than 100, meaning no heart failure, and then greater than 300 for mild and greater than 600. I'm not going to give you like a 305 or something like that. If there is a number, it will be very clear where it is in that system, in severe or mild or moderate. But again, I would like to use my numbers. I think the book says something maybe, I think it's 400 is mild or moderate, if I remember correctly. But I think it's saying I can't remember if it's mild, moderate. So that's why I want to use the 369. I think it's easier to remember that way. And remember that if it is over 100, there is heart failure present. It's just maybe it's just not even mild yet, like we're beginning, right? So we want to do interventions, which we'll come to here in a minute, to help stabilize and help the client not get a BNP over 900. And then so again, write off the objectives, the list of objectives. And I think we see too, now that you're doing more exemplars and you're seeing different types of clients in the hospital when you're taking care of them, especially in med surg, that a lot of it is the same, with some specific things maybe for certain medical condition. So prevention, if we're going back to that primary prevention, hypertension, so diet, exercise, different medications, making sure hopefully that people can follow up and get to their provider, that they know when to call their provider. We talked about pharmacological therapies, beta blockers, ARBs, ACE inhibitors, diuretics. If there's a specific one, then I will let you know in the final Sully Sesh before the final. But I probably, if I had to ask anything, probably be a diuretic or a beta blocker. Fluid restriction. 2 to 3 liters is what they say. I kind of like the 2 liters fluid restriction. I believe we talked about how to divide that through the day. We want daily weights, right? Oxygen. So it's a little different in heart failure. Remember in COPD, we if we gave too much oxygen, what happened?
You you take the ability of their brain to send a signal for them to breathe.
Yes, right. But we don't have that in heart failure unless there's a COPD component with it. But if we're talking strictly heart failure, no, hold on one second, Brenda. If we're talking strictly heart failure, we might be up higher with the oxygen. We want to keep um, the perfusion going because there's an issue with the perfusion as the blood's not getting as much out there probably. And to decrease any dyspnea, the work of breathing decrease that. The diuretics can be used for either sided, right or left, because in left-sided heart failure, there's still excess fluid. It just happens to be more on the pulmonary side than on the systemic side. So we can use diuretics. Lasix is one that's used a lot. Lasix IV push is used. And I think I told you the story of the client we had in long-term care who, for some reason, they thought didn't need her diuretic anymore. And she ended up with heart failure in the ICU for 3 days. So it's for both types. Good question. Um, Positioning, deep breathing, maybe coughing, maybe if they have phlegm or secretions. And also the positioning can help to move the fluid. Sometimes if you turn the client a certain way, it'll help drain or move fluid because there can also be, as you know, edema. There can be lower extremity edema or pitting edema, those kind of things. So elevated legs, things like that are helpful. And also so that we don't get atelectasis. Sometimes it can be painful, a painful disease process to have going on. Low sodium, maybe small frequent meals, that kind of thing. And remember that these are the interventions that we do as nurses are individualized, or they should be individualized. So if you're given a case scenario, you have to look at that particular case scenario to figure out what you might need to do or not. You can't just sort of say, well, we're going to do this, because that's what the book or the slides say. You have to say, oh, well, for this particular client, maybe we're going to do diet and medications. Maybe they're not able to exercise based on their BMI or something like that. So we're going to tailor that to what they are able to do, or hopefully with those other interventions, their activity and tolerance will increase. And so then eventually we can have them doing some mild exercise. And then the daily weights. I think it's a good idea. We do it with clients with dietary things, with blood sugars. We keep a symptom diary or a diary of if we were tracking low sodium or something, you might want them to do some kind of nutritional tracking or something. And then that way they can bring it with them and show you, their symptoms or maybe the daily weights, those kind of things. I don't know if when you were at Eden Valley, if you were able to look in the computer and track the weights or the blood sugars or different things like that. I don't know if you had access to the health record.
A little bit, but I don't
A
know if I
little.
see the tracked weights.
Got it. So what I will do often is I will print out the daily weights or the weekly weights, whatever it is, and have students look at the trends. Is it 1 pound, 2 pounds? We do that for nutrition, for weight loss, as well as clients that have heart failure, just to kind of look at that, to kind of see the trends. And so that's sometimes it's good to see those. Collaborating with healthcare team members, coordinating care across settings, right? From the hospital, home. Um, I'll read that in a second. Hold on. Cardiology. So like a cardiologist, the primary care provider, pharmacy, the dietitian, nutritionist, physical therapy sometimes. Sometimes the clients will be coming to, a long-term care for a little bit because they have a rehab side. And so they'll come and do some physical therapy to work up on the activity intolerance. get social work involved or a case manager to help with discharge planning, or home care. Maybe VNA can come by, or some other home care agency can come by. You can get in-home PT/OT services depending sometimes. But I think it's important to understand what the person's insurance coverage is, or if they even have insurance, to be able to figure that out. I think, as a nurse, I'm probably not as up on insurance coverage because I don't really necessarily deal with that part. But I think it is good to understand, maybe if they don't have insurance, what are some other strategies we can use? That's just an overall comment. That's not something necessarily for the exam. But just know that there's many different pieces to that. Okay, let's see. Alex says in heart systems, medical tends to focus a lot on electrolytes, particularly potassium, calcium. Yes. Are you going to ask specifics regarding hypokalemia around heart diseases or medications like ACE inhibitors? I was not planning on doing that at this point. I would focus more on like the calcium, phosphorus when we were talking about the parathyroid glands, that type of thing. But I'm not, the focus for this is more the fluid balance, not the electrolyte balance, if that makes sense. Yeah. Yep. There is a lot. You are correct. So yeah, keep asking questions like that. I'm happy to try and narrow it down as much as I hopefully can. And if I change my mind, which I don't think I will, but if there is something, I would let you know for the exam. And then of course the psychological impact. These are the same objectives, right? These are the things that we're, as nurses, we are concerned about. So what kind of things might the client or the family be experiencing? Anxiety, lifestyle changes, maybe fear, maybe if it's an older person and they have Alzheimer's or some types of dementia, or maybe they have hypertension or diabetes, and so now we're in multi-system failure, things that we're looking at. So there's all different types of things, and so we want to, of course, use therapeutic communication. Maybe refer to support groups through the social worker, mental health counseling, to be what was I thinking? Refer to mental health or counseling, like in the support groups as well, but they might also have depression. And I think sometimes we forget about the caregiver, right? The caregiver may also suffer from burnout. So we want to try and include them. We talked about that today a little bit with the spinal cord injury case study in terms of the wife. And so I think it's important to include them in the education. I would love to see, I don't even know, but like more handwritten, or maybe, they could do little videos or something to, yeah, it's hard. Substance use cessation is not easy. So if there's support that we can give to them, I think that's great. Encourage them to go. As bedside nurses, we're not necessarily going to get the chance to follow up on that. But if you are like a case manager or something, or home care nurse, then that will be a big part of what you're doing. And the education, self-care, those kind of things. And I think it's also important. We talked again a little bit today about when are we going to educate. I think we're seeing, at least in OB, the education, at least on the postpartum unit, that's starting when they get there. We have to keep giving little pieces and kind of building until they're really able to understand what's going on, or the lifestyle changes that they might have to make. And that was pretty much the objectives. Again, I tried to highlight things that I think are important for you to know. Let me make that a little bit smaller again, because your eyes are probably all better than mine. So what other, like Alex had a good question asking about electrolytes and such. Hopefully that shed a little more light on it. But I'm happy to take any specific questions. Let me stop sharing. There we go. And then my hope is to continue to do those for like elimination, spinal cord. I'll keep on doing doing that. Take a little 2-minute breather and I'll put up the congenital heart disease study guide. Does that work for people?
Yeah,
Yeah.
that'd be great.
Okay, sounds good. Let me go find that. Um, doo, doo, doo. Let me find. Now remember for the congenital heart disease, you also have the handout that I gave you in class that has the pictures of everything. You can have that somewhere. And so I think if you use that along with the study guide, you will probably find that to be helpful. Just because I'm a visual person, if you're not a visual person, then maybe not. But I kind of have to look at pictures of things. I did not put fetal circulation on here. I should have something with fetal circulation on here. I will try and do that as in terms of the shunts. Let me close that, find you. You like the study guide. Thank you. So I will add something on here and re-upload and repost it so that there's fetal circulation for sure. Let's talk about fetal circulation a little bit. But I totally was so focused on the defects that I forgot. I'm realizing now to put something there on fetal circulation. So let me share my screen and make sure I've got the right one up. Screen two, share. Find my, not the right one. There we go. Ah, that's what I want. Chat. Here we go. Okay, so I have the chat up, I have the study guide up. So talk to me about what what do you remember? What do you think is important to know about fetal circulation? AVA, yep, the two arteries in the vein, yep. And what else? Yes, the lungs are not involved, so the shunts and the placenta, yes, Hunter. And so whatever diagram you can find to look at that in terms of the placenta, and then knowing the shunts. I'm trying to think if I have the picture. Um, hold on, let me stop sharing for a second. Let me see if I can find the. Hold on one second. Let's see. When I type up the transcripts for these, I take out all the little extraneous comments and try to just leave the information. So if you looked, for example, at the hormonal one, hopefully some of that was mostly just hopefully information. Let's see. Ah, there it is. Let me pull. So, okay, let me share yet again. Screen two, share. Okay, and then find my chat again. Yes, there we go. So Kat says 3 shunts, one away from the liver, one away from the lungs, and one between one between the atria. Yes. Nice. So is it the fetal circulation is what you see on your screen?
Yes.
Yes, thank you. So you are correct. So the one that the ones that I'm really more not concerned isn't the right way, but that I want you to know would be the shunts in the foraminal valley and the ductus arteriosus. So ductus arteriosus is going to the aorta, and the ductus venosus is the liver shunt. But I'm focusing more on the respiratory ones. And so understanding what they're doing in the circulation, just at that basic level that we're trying to bypass the lungs because we don't need that oxygenation. The placenta is doing that for the baby. And so then let me go back to the study guide. Do you see the study guide now or still the fetal circulation?
Study guide.
The study guide. Nice shorthand. Good job, mama. Okay, study guide. So we've got that understanding, right, of the fetal circulation on that basic level. And so when we're looking at critical congenital heart defects, those are things at birth, right, congenital, that are affecting the circulation. And if you think about it, really, the cardiac output, stroke volume, and heart rate, mostly the stroke volume is being affected. And so it's also heart failure as well. So if you think about it that way, it can be compared to adult circulation as well. So the heart defects that I'm wanting you to focus on are the cyanotic, which is the right to left shift in terms of the hypoplastic left heart, transposition of the great arteries, and the tetralogy of Fallot. I generally always ask a question about tetralogy of Fallot and then may choose one from the other cyanotic defects, and then looking at the acyanotic, looking at the ASD, VSD, so atrial septal defect, ventricular septal defect, the PDA, the patent ductus arteriosus. In some cases, that it's a good thing that stays open, as well as the coarctation of the aorta. I generally ask a question about coarctation of the aorta, and what kind of question do you think I would ask about coarc? The BPs, yeah, probably. And what do you need to know? What are you noticing? What is it that is a sign or symptom of coarctation that has to do with the blood pressures?
Different blood pressures between the arms and the legs.
In what way?
Oh, you got me.
That's okay.
Reduce blood
In
pressure in the legs, right? Because it can't get down there.
Yes, yes, exactly. Good. hmm And then the ASD and VSD aren't really, there's not much that's not really symptomatic. We see those more commonly. And I have a little picture here for you coming up. Screening and diagnosis, again, to know that we do the congenital heart disease screening. I think several of you have seen it and or actually participated in it with the pulse ox on the right and the one of the lower extremities at the same time. What I've been seeing is that a lot of our vaginal delivery moms, they're going home within 24 hours, and a lot of the C-section moms are going home within 48 hours instead of 72 hours. So our time for education is cut very short, as would be our time to recognize or notice if there are any difficulties. So we definitely want to do the pulse ox screening after 24 hours. And then if it's lower than 90% or there's greater than a 3% difference between the hand and the feet, that would be a problem as well. We actually had I'm not sure if anybody's here that was able to see the baby, but we have a 27 weeker in the NICU at Natividad, and they actually were getting pre and post ductal pulse oximetry continuous pre-post ductal oximetry. And it was interesting to watch the preductal, if they started to do something with the baby or readjust the endotracheal tube or do something, the preductal would drop first, and then you would see the postductal drop. But once the baby recovered and they would increase the oxygen, the FiO2 on the oxygen, and the baby would calm down, they would stabilize and be almost the same. Again, it was really kind of cool to watch with that. And that baby, which I'm not asking you to know, but had a really big patent foramen ovale. So I thought that was kind of interesting as well. They originally thought the baby, no, that was a different baby. Never mind. I thought that was Coark. That was a different baby. Again, doing echocardiograms, that's a huge thing that we use for diagnosis. We can do cardiac catheterizations, the chest x-rays, not so much the rhythms unless we feel like there's a big problem, but most of the time echocardiograms. And so there's just a little chart I try to kind of put together for you for the acyanotic defects of the things that you would notice maybe, and then be thinking, oh, okay, for sure the blood pressure, right? Doesn't mean that there is a coarc, but that is one of the cardinal signs for that. In the patent ductus arteriosus, it's usually normal, and we're not even really looking at that. Blood pressure isn't really affected in ASD or VSD. The pulses in coarctation are weak or delayed femoral, right? Like Alex was saying that it's less in the lower extremities. A PDA will actually have bounding pulses because it's pumping. There's more blood coming because you're going from the pulmonary circulation into the aorta. So you're going to get bounding peripheral pulses. Different types of murmurs that you might hear, but basically they all have a murmur. And then symptoms, they're all going to have poor feeding, right? We've always said poor feeding, poor weight gain, perhaps because of the poor feeding. FTT is failure to thrive. So those things you may see, like especially in a ventricular septal defect, whereas the atrial septal defect is a little more asymptomatic. And why do you think that might be? Let me ask it another way, maybe. Why would we see symptoms more in a ventricular septal defect than we would in an atrial septal defect? Think back to the heart failure one we just did with the adults. Pumping from ventricles. Woohoo! Yes, because that's where the blood is going. The blood is going to the lungs or to the body from the ventricles. And so we're going to see more types of symptoms with that. Whereas the atria, it's just often asymptomatic. You may see something later in adulthood in terms of it's harder for the blood to be oxygenated. But yeah, great. That's great. Good job, Kat. Yeah, Alex.
So in ASD, you're saying that the holes are in the atria, in the
Mm-hmm.
chambers.
The
Um,
whole, yeah.
yeah, or and they're smaller, right? So as they grow older, they get bigger, the holes.
Potentially, yeah. If they're not, sometimes they'll actually close early on. Other times they do remain open. And so they can there can be more effect as the heart ages and is less compliant, and the circulation kind of can change a little bit, or if they're getting congestive heart failure for those other reasons, they can get bigger as the person grows older. Yeah.
Okay, so that's the idea behind the asymptomatic until adulthood.
Yes.
Okay, thank you.
Mm-hmm. Mm-hmm. Good question. Um, so is kind of like a summary for that. And then nursing interventions that you're going to see things again that we've talked about. Um, the high calorie, we talked about putting the extra calories in the formula or the breast milk supplementing, small frequent feedings, um, feedings maybe that take less than 30 minutes or less. Maybe they will bottle or breastfeed, and then we'll switch and finish with an NG or gavage feed to help with that, to keep the metabolite, to keep the calories up. Um, Watching during feedings about respiratory effort, that kind of thing. Correct. The foramen ovale is correct. Yeah, they would still probably call it a. It was interesting on this baby. They said it was a big foramen ovale, and I'm thinking to myself, well, maybe it's a foramen ovale and an ASD that kind of went together. I always try to think of a foramen ovale as a type of ASD, but it generally closes. So if it stays open, they still would call it a patent foraminovalle because that's where it started, but it would then be an atrial septal defect because the blood is crossing from the right to the left atrium. So yeah, so for testing purposes, I wouldn't be asking specifically about the foraminovalle. It would be more an ASD. I'm not going to get picky about that. But good question. That's always the question. And that's the best way I can think about how I'm thinking about it at this point. What do we say? Oh yes, watching while they're feeding in terms of the respiratory effort, are they desaturating? Fluid restrictions if they would be needed, following the orders, different medications maybe. There probably will be some type of question on well, no, we kind of already did a medication. There'll probably be some kind of medication calculation. I'm not sure yet. But I would, if you were going to focus on a medication, in this case, diuretics and probably digoxin, if we needed that, that's for heart failure. For the infant, we want to know the history, the vital signs, and again, we may just hear a murmur. So basically, we're doing basic care, right? Unless it's maybe the COARC or the PDA, then they might go to the NICU for a while. But just the basic care that we're doing, watching the feedings, watching for any changes, any volume overload. The feeding intolerance is always a big one. And any diaphoresis, babies don't perspire, babies don't sweat, or they shouldn't be. So that's why if we see that in neonatal abstinence or in heart problems, then there's a problem. Volume overload, all that. Murmurs, again, we are not asked to define what type of murmur, just to recognize that there's a whoosh, whoosh, or some kind of alternate sound that's not a lub dub sound. I won't ask you the systolic is like a three type murmur, or the diastolic is like a four step murmur, whatever. I'm not going to go that deep into it. And then still the daily weights and potentially intake output. We're always checking how many diapers, how many wet diapers, how many soiled diapers, poopy diapers. Anyway, and then, members of the team that might be needed for follow-up, any education, developmental milestones, right? Going back to development, are they meeting their milestones? If they have to maybe go home on a pulse ox or anything, is there any education that you'd want to know? If they have had surgery, right? They might come home on a pulse ox, or they might have an incision that we're going to have to teach wound care for if they've had surgery. Lots of times with the COARC, they'll do surgery. VSD, depending on how big or how symptomatic the baby is, they may or may not do surgery. And I always think support groups are good. And then the final kind of section to talk about for this evening would be the clinical manifestations for the cyanotic defects. So the three, the TET, the transposition, and the hypoplastic left heart. So these are we used to call them blue babies because of the cyanosis. And so the lips, tongue, mucous membranes, the central kind of cyanosis, or it could be acrocyanosis that doesn't go away. Usually we expect it to go away when? When do we expect to not see acrocyanosis anymore?
Like 1 to 2 days?
Yeah, usually 24 hours. I might go 48, but I'd be starting to do some assessments, or really listen for murmurs or something. And the other thing is that it'll be acrocyanosis, but the extremities will be warm. They won't be cool. They'll be warm because things are perfusing, but there's how do I want to say it? But it's not the because it's a cyanotic defect. You might get acrocyanosis. It's not going to go away. You might see the tachypnea with the grunting and the nasal flaring and the retractions. Poor feeding for sure. And again, we talked about, I think, in terms of like tetralogy, they will do they'll do surgery, but it doesn't have to be immediate transposition. It's going to be an emergent type surgery. Hypoplastic left heart, depending on how big the ventricle is, because it's the ventricle, like Kat was saying, it's the ventricle that's pushing the blood. And so that they may also, have poor feeding with that. It may take a little longer to figure out that problem. Although the baby will have the central cyanosis, different kinds of murmurs, activity, intolerance. One of the things you might see is clubbing. Remember in that newborn assessment, we talked about clubbing might be something that you're assessing for. In a heart defect, especially a cyanotic heart defect, there might be, would be more prone because it's heart failure to see clubbing. Especially after, because we're talking chronic hypoxemia, right? Not having as much oxygen as we should have, not perfusing as well as the heart should be perfusing the body. You can also get polycythemia, so an increased number of red blood cells, because there's the hypoxemia, so we're trying to make more red blood cells to get more oxygen to the body. And then we did talk about in class the TET spells, where there's like a sudden cyanosis, and if it's like irritability, crying, if it's an older child, they still might cry, but in a baby, you're probably going to see the color change right away. And so you want to use that knee chest positioning. And then nursing interventions, again, this would be more immediate, like when the baby's born for a cyanotic heart defect. Any medications, we'll probably be using prostaglandin E, because it will help keep those shunts open that we want, because we need to shunt blood certain ways. I wouldn't ask you a question about how the shunting would change or something like that. I'm just letting you know that that's what would happen. But oxygenation, right? The respirations, we've got to make sure that they're oxygenating. So if they have respiratory failure, to have them on a ventilator, to titrate the oxygen. The baby, the 27-weeker that we had, started out at 100% oxygen, and after about 3 or 4 hours, we got to 40%, but that was about where the baby could tolerate. They really, at the time that we were there, could not drop it below 40% oxygen. The baby wasn't tolerating it. So being careful about that. And then fluid, we don't want to fluid overload the baby. So those calculations are very important in terms of the fluid calculations, and how much TPN, because the baby would be on TPN, lipids. We're probably not going to feed them initially. And then getting them ready for whatever procedures that they would be, any diagnostic procedures or actual surgeries or transports. We had a transport last week, I think. And so that's a whole big production of paperwork and documentation, and waiting for the team to come to pick up the baby, getting the baby ready to be picked up by the transport team. Especially if we're not able to, whatever hospital where we are, to take care of the baby in the way that it needs to be taken care of. And then always teaching, coordinating, social services comes in, like chaplain will come in, maybe the mental health type person might come in, social workers, all that kind of thing too. Calls up to if they're going up to Stanford or something, on the phone, constantly giving report, talking to the doctors up there. What suggestions do they have based on the symptoms that we're seeing? It's going to be difficult to teach the family, because can be, say it's transposition. This is an emergency, right? And so trying to just be there, let the parents see what's going on, but not keep you from doing what you need to do. Once the surgeries, maybe the baby has the surgery, now they're coming back for what we would consider to be rehab for a baby. So they would come back to us in Salinas perhaps, and then we're going to then teach them about things like apnea monitor, or pulse oximeters, things for home care, which is why I love it that you get to go to Coastal Kids, because you may see some of these babies that have had these surgeries and are doing well, and excuse me, but still need to be monitored, or have higher calorie formulas or things like that, and follow up. So those are not things that are the immediate interventions are highlighted. I'm thinking more respiratory, perfusion wise, and then potential long-term considerations or things, the against a child that might be at Coastal Kids. How are we going to feed them? Are they at risk for developmental delay? I'm not so worried about endocarditis. We're not really talking about that in this particular example. Cardiology follow-up they'll probably need, that kind of thing. Um, so what you would need to know, let me scroll back up to the top, make sure that we're clear on that. I will add fetal circulation onto this. And so the shunts would be the important thing and why they're being utilized, why we have them. Knowing the right to left, left to right shunts, the cyanotic versus the acyanotic, the screening or diagnostics that are done. We did talk a little bit about cardiac catheterization in class in terms of post-op care for cardiac cath. Do you remember what you had to do? Some of those things that you had to do for that, for cardiac cath post-op? What assessments are we doing? After cardiac catheterization? Where's the catheter inserted and where's it going? Cardiac, right? And in terms of cardiac, what pieces of say a focused cardiac assessment, what piece of that? The wound, yes. What about the wound? What are we worried about?
Bleeding.
Infection. Oh, go ahead, Alex.
Oh, I said bleeding.
Yeah, bleeding. So infection and bleeding would be your number one priority if there was bleeding at the site. So we often keep a compress or weighted something on there to keep it covered and keep it hold a pressure dressing, something on it, definitely. And then what else are you looking at in terms of maybe the cardiac part of a cardiac assessment?
Mm, I would imagine if you're going into the heart, any arrhythmias that may occur.
Mm-hmm. Yeah. Mm-hmm. We also just stuck a catheter in a leg, in a femoral.
Clots,
What clots? What about below the site?
perfusion,
And so what are we going to assess for that?
pulses.
Yes. Mm-hmm. Pulses, color, cap refill in the toes and the feet. Mm-hmm. Yep. And then again, the signs and symptoms, the blood pressure. I told you that, the basic nursing interventions to do, what you might see in a cyanotic defect that's different than an acyanotic defect, and focusing mostly on the oxygen stabilization or preparing for procedures. Um, yeah, I think that covers that. Perfusion, yeah, good job. Um, questions? Did I confuse you more? Does it make more sense? Let me stop sharing. Yes, very helpful. Good. Okay. Helps a little bit. And let me know. I still have, office hours or you can make appointments or something. I'm happy to do that. I think what we'll do on Monday is cover the maybe not. You guys are going to be pretty brain tired. We might just do the elimination, I think, on Monday, just because we've covered that already. And then maybe move on to the seizures and the stroke after that. Did you cover stroke in any way in first semester with like mobility or anything? No. Okay. So we'll do the basics of ischemic and hemorrhagic strokes and all that. Okay, cool. Um, let me So it sounds like people are good, that was somewhat helpful. Let me go ahead and, or maybe not somewhat, hopefully it was helpful, not just somewhat helpful, moderately helpful, very helpful. Let's see, where is my pause, stop recording? There we go. Yes.